Mr. Tufal Ahmed, sir. Can you hear me well?
Yeah.
Oh, thank you. So let me just share my screen. Okay. I hope you can see my screen also.
Yeah.
Everyone can see my screen, right? Okay. All right. Thank you very much for giving me the opportunity. It's really a wonderful feeling, to be honest with you. This is my first talk, in front of all the audience from Bangladesh. I've been speaking in various conferences in Europe, America, Australia. It's a great privilege, and it's really beautiful. Greetings from New York. It's midnight, almost going to be midnight. And when I was really get the invitation, like I knew where I am stepping into, like all the brilliant doctors, right, in my country. And I was really sweating, like what I should be talking, because I'm an computer vision person. Like I did my PhD in computer science, pure computer science. And it was looking into the retinal image. And we are trying to extract the features from an image. Like if it is a color fundus image, what is the width in terms of the pathologies, using computer vision, machine learning. I tried to develop a new data structure so that we don't need to go for traditional image registration. Like usually you superimpose in one image into another image and try to match with the various combination and see what is the difference if a disease is really progressing from its previous stage, or is it better, like in terms of the pathology. So really trying to do the mathematical modeling, avoiding the registration, and like doing the comparison of two images. So this idea of this screening really came into my mind in 2009. Like when I first joined at Center for Eye Research Australia, following my PhD as a postdoctoral research fellow. I was like working with the doctors, like who are mostly ophthalmologists and neuro-ophthalmologists, and looking into the images, I wondered like, hey, what's happening here? How come the patients are so bad? Like, how come that big hemorrhage, like inside their eye? What, like you guys were really doing? And the answer was, guess what? Oh, no. Like when they were in front of us, we did not have any opportunity. We just had to inject them or burn that particular, like, place. We just could stop that, like damage. And that like so far, we don't have any treatment for regeneration. Whatever is gone is gone. Currently there are some like, gene therapy studies, and we may be able to see in next 20, 30 years, like, good form of regeneration. So given that idea, we have been working on telemedicine and this image-based and artificial intelligence-based, like software tool to screen these patients really, like who are at risk of diabetic retinopathy or age-related macular degeneration or glaucoma, like this sort of ophthalmic disease, along with cardiovascular heart disease or stroke. Like eye is the window to the, like the body. So using this motto, like I formed my company in 2015 when I was at Harvard as a visiting scholar with my Endeavor Australia Award. And then there was some nice NIH scheme here for the like research grant. If you wanted to do pure research and make it as a traditional research, like you have the opportunity to apply, and if it is a good project and really like, making impact, very high chance of getting it funded. So that's how I started using $500,000, like a small seed funding. And the disclaimer is this entire like, talk is for my company. Actually, I'm not representing Mount Sinai here. I had other research projects for Mount Sinai, but this diabetic retinopathy screening is like my company initiative, iHealth Screen. And thank you once again for listening to this, and giving me the like wonderful opportunity. So I know most of you are very familiar with this. Like if you can like revisit what a diabetic retinopathy patient can see in the right side, we can see the top image is a good vision, like a healthy individual can see. And the bottom image is the like, severe stage diabetic patient can see. It's a leading cause of blindness, like because of like, diabetic patients. Because of like uncontrolled diabetes, and it's around the world. And there's no early signs. Stay in the back of our eye, the retina. And if we can look into this one, it's good. Otherwise, we don't know. In one day, suddenly the patient realized that he or she cannot see, a particular area, like in that visual field. And it's always late, like visiting the ophthalmologist, because if we don't have problem, we don't go to ophthalmologist, this is human nature. And we know that there is no treatment. Once blind, it is blind, So prevention or preventative measures is the only option. And at present, there are limited tools to diagnose this, like, early stage diabetic retinopathy. And we have limited ophthalmologists. We know that, like, we cannot, like, put an ophthalmologist anywhere in the remote rural areas. Like, they are really limited number, even in America or Europe. And that's why we are really seeing that the numbers are getting more and more, like, I'm coming to the numbers, like in exact, being specific. So what's really happening, NIH did a research, like even though they have insurance, they're covered by the insurance companies, they can really visit their yearly screening, no out-of-pocket money, the insurance will be paying, and the patients are not going to see their ophthalmologist. This is really, like, interesting, isn't it? Like, and NIH like found the reasons, like they try to see why they're not going, because you have to make appointment with them, and I don't have any problem, why should I go? And sometimes they make appointment, they miss the appointment, they have to take days off, from work. There are many other reasons. So almost half, 50%, like five out of 10 are missing out from the regular screening. And we know that, like, really these 90% of these subjects can be, prevented through regular screening. If we can do this, like, screening on time. And the numbers are growing. So the focus is to take this screening in the primary care level, like the dietitian or internal medicine, like we usually visit, like our regular visit. And if we can really do the screening from that, like particular site, we can make sure that we can deliver the screening. We can identify these individuals at risk of diabetic retinopathy getting moderate to severe, progression into moderate to severe, and then pick them. And once we show them what's really going on, you will be blind, then definitely, like, they will be listening. If we see the direct number, like in 2020, we have 6 million diabetic retinopathy cases here. And it will be over 11 million by 2030. This is really scary, and we know that like the other countries, we are also having an increasing number of diabetic patients. And this is the direct cost, like we do inject, we do the laser treatment and other costs. The indirect cost would be more than $100 billion because of loss, like injury, loss of work, or like injury due to fall, like there are depression, there are many other reasons, like from this. And if we look into the number of diabetic patients in Bangladesh, I was trying to find the exact number, very specific numbers I could not locate, probably and you can add here in the chat box. I had some questions and I tried to figure out like an estimation, like what the number could be, what the direct cost, and what is the projection of the number of diabetic patients in Bangladesh. So I looked into a study by Mukit and others, like which was published at JAMA Network Open, open source journal, and they studied with 49,264 individuals, and they showed that like the prevalence of pre-proliferative diabetic retinopathy 3.9%, and proliferative diabetic retinopathy 7.8%, and 19.2% for maculopathy. I would take them all really referable and severe to progressing to severe case. And if we see the numbers for moderate visual impairment, 12.2%, and the rate of blindness, 2.5%. So really getting visually impaired almost 15%. So it's really, really scary. And the number of subjects was really like, nice. And it's above 49,000, like subjects they studied with balancing the male and female, from 3 different sites around the country under PADAS, facilities. So now we can really like, guess what the number of diabetic retinopathy patients could be. Probably in future we'll get the exact numbers. So given that, like this is already, I think, is in a dangerous situation, what's going on around the country. We hear like many of our like, known, like or connections are getting this problem, getting blinds. So what we are really offering here, we take this software with a retinal camera into the primary care clinics. Like for example, like if it is a diabetic facility, like diabetes hospital, probably in the outpatient department. And we take the individual's retinal image. And what we really do here is we already did, let's say, millions of images, and we had different categories, let's mild, moderate, severe, normal, like those categories, proliferative, non-proliferative, diabetic retinopathy examples. And we did train with the artificial neural network. It exactly works like how our brain works, like connections of neurons. And we just try to find features to differentiate objects, like the similar idea we do here. If we look into the, like how artificial intelligence works in a computer is, we try to make the class and try to see what is the difference or what is the similarity of this object. For example, for our case, it's an image, which is like really getting closer or less difference or less error of being belong to a class, particular class. For us, it could be mild or moderate or severe diabetic retinopathy. So if we look into an image, you try to see what are the different features. Is there any, let's say, microaneurysm, or is there any hemorrhage, or any of these pathologies for diabetic retinopathy, and apply, let's say, partial differential equations there, and then make the difference, try to find, let's say, error between like two class and the distance between the two class, and then you can assign each of these one. And after that, we did, let's say, a classification measurement accuracy. Okay, so in simple, way to explain is, okay, we have an image, we try to fit this image into a class. And then we say that, well, based on this image, this is the mild stage or moderate stage, or like, let's say, severe stage of diabetic retinopathy. And if it is a mild or normal stage, we don't want to refer this. If it is a moderate stage, we want to refer this patient to the ophthalmologist. And this entire process can be done within 5 minutes. Like, let me show you like how we are really doing this. So we are using a fully automated camera. Just a simple touch button, you start, and both eyes will be imaged within a minute. So what we do here is like we upload both image, left eye, right eye, and then we submit it to the platforms, the software platform, and the software automatically runs it and then generate the report. So this is the report like that finally we get. So this report can be archived for the future reference. Like if the patient revisits, then we can see if the patient is progressed or like, or like, or it stays in the same condition. So the benefits of our screening tool is highly accurate. You can see it's more than 97% sensitivity it achieved, and more than 99% specificity, and the AOC area under the curve, it provides 99%, like population group with that accuracy. So in general, we can say it's above 95%. It takes less than 5 minutes from image capturing to generation of the report. And above all, we don't need the specialist in that remote areas, in that like, remote clinics. We can do as like service, as a specialist service. It's a digital prescription. And when necessary, we can take this patient and then refer this patient to the ophthalmologist. And ophthalmologist can then further do the, diagnosis and treatment. And of course, it can provide like early detection and prevention, of like, it helps in the prevention of diabetic retinopathy. And how did we do? Like in terms of like using different data sets, there are two very famous data sets. One is Kegel in America, and other one is the Messidor in UK, United Kingdom. And we did almost 100,000 images from Kegel dataset for building and training and testing, and 10,000 images, above 10,000 images for validation. And we did the external validation using the Messenger 2 dataset, more than 2,000 images. If we look into that, the numbers, the sensitivity for Kaggle data set is, let's say, above 99%, and the specificity 97% and above, the accuracy above 97%, and for messenger 2 is similar or higher. Okay, and we have a predicate device. It's named IDX. They also do the similar service, and our accuracy is better than them. You know, using the same subjects, same data set, we compared and we showed that like our system performs or outperforms like IDX. And we published this in the Diabetes Care, the #1 journal in diabetes. You all know that. So it was accepted in last August last year, and our work also featured at the ARVO, Research and Vision in Ophthalmology Conference, the largest conference, and we also recently covered by Retina Today, and our AI and telemedicine using these tools for screening age-related macular degeneration, diabetic retinopathy, and glaucoma. These 3 different screening using one tool, and it was featured in the Retina Today, the last month's one. So once again, this is the report. Like in the report, we can see like the referral reason, of course, diabetic patient. We can see the doctor's name, and what are the different pathologies that could be there. There will be description and the recommendation. You know, and if needed, we have the option to refer this to the ophthalmologist from this tool. This is all in the cloud-based, and this entire process is very simple. In terms of like as a company, where we are now, we are like fully funded by National Institute of Health, NIH, and as a principal investigator, like I has received like 2.5 million so far, and another $2 million like we are expecting to receive this year for stroke prediction. And besides our diabetic retinopathy, macular degeneration, and glaucoma screening, we also have developed the prediction model for stroke. This is also AI-based. It was presented at the neurology conference, 2019, and we have submitted the paper now in the Journal of Stroke. And we are featured at the ARVO, the largest conference, and in 2020, our work on macular degeneration was in the panel discussion. Like they usually pick 6 research topics, and from each of this topic, 1 work they picked. And the American Academy of Ophthalmology selected our work in their panel discussion on the prospective trial of macular degeneration. This is my group. This is my colleagues, the scientific advisory and my regulatory. And we are like, partnering and working with NIH, of course. Mount Sinai is my university where I am affiliated with. And my colleagues are from Wisconsin, New York University, Johnson & Johnson. So like we have been like, offering our service to BADAS. We have an agreement with Bangladesh Diabetes Society. It's a great pleasure to mention this here. And our plan is to put a retinal camera and our software in every diabetic hospitals, basically the major hospitals, and screen the individuals who are at risk of diabetic retinopathy and bring them in front of the ophthalmologist, and help prevent this diabetic retinopathy, and we have the bus receipt from BADAS, thanks for this, so that we can really travel, like my team can travel to the remote areas, so this is where we are now, and hopefully the pandemic will be over, and hope everyone will be, staying safe, and yes, we will be able to prevent diabetic retinopathy with high impact. Thank you so much for your attention. I'd love to take some questions, like if you have time, if we have time. Right?